Okay, everybody, it is 8 o'clock, and I'm so excited to be joined by such a awesome panel.
thinking about aortic issues. I don't really necessarily think from a PE standpoint I'm getting that, but still tachypnea, tachycardia, something to consider. Mike, you mentioned acidosis. That's great in someone presenting with shortness of breath, clear lungs. We've got to keep that on the differential, whether that be from an alcoholic standpoint, whether that be from perhaps this person who is using substances may have gotten or ingested a toxic alcohol infection. Always I'm thinking about that in terms of sepsis and just resuscitation and critical care. So I probably would continue to do the diagnostic evaluation, whereby while I'm also assessing inpatient sources and where is the safest place or level of care within the hospital that this patient would go. Right now, it's not necessarily changing mentation or demonstrating hemodynamic instability. It might be reasonable to put on a monitored or telemetry floor given the tachycardia and tachypnea while continuing to undergo evaluation. And if there's any hint that I'm suspicious of, we're starting with the early signs of alcohol withdrawal, absolutely starting to medicate the patient out up front so we're not resulting in a crash a few hours from now.
So I'm going to throw this question out, but for very brief answers for the rest of the folks on the panel. Before I do that, I want to just very quickly back up to this heart score. And, there's so much literature now on the heart score, and people use this commonly. I will say that myself, with a research group, presented at the American Heart Association last year a study of moderate risk heart score patients, and not saying go home, you're fine, but an expedited outpatient evaluation compared to admission, there were not really worse outcomes from that. And so there's a lot more of these studies that are coming out. There's several other ones that I'm still currently gathering data on with this. But to me, anyway, and I'd be interested in some of the thoughts from the group, it feels like there are so many other things that are going on with this patient that just simply putting him in a heart score, and of course, the patient's not going to be based on, his age, and then you get obviously an automatic risk factor if you have a history of atherosclerotic heart disease, that the patient is going to automatically be moderate risk heart score either way. So just as far as the simple question, not the heart score question, but as far as going back to the simple question from everyone else, Josh, I'll start with you. Do you feel comfortable sending this patient home? Would you admit the patient? And if you do, would you start any medications at this time?
Yeah, well, I agree with everything that Mike said. And to me, it just seems like there was a lot of anchoring on a disposition right off the bat without really a consideration of differential. And once that disposition was arrived upon as being an admission, then it seems like the doc was kind of just ready to move on. And so there wasn't a discussion of another differential. There also wasn't a discussion of, does this patient need more than a disposition decision? Does he need further evaluation for other conditions that could explain his presentation? And do we need to do something about the fact that he's got unstable vital signs? So I don't see that alcohol withdrawal really entered his mind. I know we're going to talk more about alcohol withdrawal, but it's interesting because he does make a point of, I shouldn't say he, that doctor made a point of mentioning the alcohol use in the first line of the HPI, but then alcohol withdrawal is not considered. So it just feels overall that there was a quick decision about the disposition, and everything else is a little bit dismissive and just trying to make the most expedient exit of this patient from the emergency department.
Okay, Whitney, what are your quick thoughts? And then Heath, and I will tell you the patient's labs and what actually happened in the emergency department.
I will quickly just say that nobody's perfect, and I might also be guilty of this. If you're crushing through at a community site and you're seeing 3 patients per hour, it might be easy to say this is decompensated CHF and admit and move on. So I can't really knock the physician very much. The one factor that I will add that would make me lean towards admission is that nobody has really thought about his social or structural determinants of health. So some of those things that are a barrier to his outpatient care would be the things that immediately stop me from discharging this patient, medication noncompliance, his social issues with his home life as well. So those things in themselves, outside of all the other things that my colleagues have said, would make me want to admit him.
Gotcha. And Heath, bring it home.
Yeah, I agree. Everybody said it well, and I like what Whitney said also because no one's going to see this guy in 24 hours or 48 hours, or he's not going to. He's going to go home and drink more. He's going to use cocaine. We also, this flashes back to when I did my fellowship in a county hospital, and on the old screensavers, they would always say, does your patient have unstable vital signs that you can't explain? And I'm like, yes. And it was like, these patients do not get discharged. And, Mike and I, doing our medical legal work, this is something that, attorneys hit run right away. It's like, doctor, how do you explain this tachycardia? How do you explain these things? And so far we haven't.
So what we have lab-wise, white count of 12,000, not a big deal. Hemoglobin 9.2, platelet count 92,000, and Josh had talked about some of that thrombocytopenia that can be seen. Sodium 128, his serum bicarb 21, INR is 1.5, and he has a BNP of only 236. So we usually think less than 100, maybe less than 80, probably not heart failure. Over 400, very likely, or certainly could be. Between 80 and 400, not really that helpful. So this is 236, not really very helpful. So what happens next with the patient? Hospitalist is called, they accept the patient for admission, and now the patient's condition has progressed. So that thought on keeping this patient certainly was a correct one. He's now slightly confused, more tachypnic with a rate of 24, was 22. Heart rate was 123, now 141. Still hanging in there with the sats, but he is diaphoretic. And he's asking for something for his nerves. So let's bring us back now to decision point B. And what I'm going to do is throw the first question out here to Dr. Johnson and some of the signs and symptoms of alcohol withdrawal and DTs, please.
Yes. So think about using alcohol as GABA activation, right? So everything down, down, down. And then when you take that away, it's all up. So without these like accumulative effects of having like NMDA receptors and having this absence of ethanol mediated GABA activation, now you've got hyperexcitable, everything looks sympathomimetic. So you're going to have tachycardia, diaphoresis, blood pressure is going to be elevated. You might notice the hand tremor. The one thing that folks can't fake is the tongue tremor. So the tongue fasciculations that we think about, that's a key one to look at. And any type of like just anxiousness, nausea, vomiting, psychomotor agitation, kind of like you have outlined there, would be for withdrawal. Mild, moderate, severe, there's stages of it. But then DTs is like our severest form. And at that point, you're looking at an encephalopathic state. So you've got a couple of these things in this list that you have pointed out here, but now you've got this decreased attention to their external environment, this decreased awareness, this disturbance in that, be it them hallucinating more or slurring their words, being incredibly altered. So that is where it starts to become more severe.
So Heath, let me ask you a quick question. The difference between alcohol withdrawal seizure and the DTs, because I think we've all had patients who seize, they get brought in by the squad, they're no longer seizing, they have a strong history of alcohol use, but a patient with the DTs obviously has a higher mortality. How do you differentiate between alcohol withdrawal seizure and between delirium tremens?
If I can get my mute to go away. Yeah, and I
Yes.
like what Whitney said also, and this guy's starting to have some mental status changes, and that's really important. But I would have liked to have gone up to him and just said the simple question: have you ever been with withdrawal before? Have you ever had a seizure? And a lot of times patients will tell you right off the bat, because that makes that gut feeling when a patient says, "Oh, I've had a seizure before from alcohol." I'm thinking, great. And so that's a big thing right here now is what is, where is this person at on this kind of the scale where they're using C or something like that. But as long as he is having, this altered mental status, right away, this is badness waiting to happen as far as I'm concerned. Now, Grant, I know the outcome of this case, but that's something that I don't like because I don't have another reason for this point. So when you're having a patient who's feeling shaky, but now having some mental status changes, this is something that you have to be really concerned about in this case here.
Yeah, we've all had patients who actually use while they're in the ED, use something, right? This guy, though, came in, he wasn't altered, and then became altered with obviously the change in vital signs too. So I think we have to be thinking, is this impending, is this, alcohol withdrawal that's going to have an impending seizure? So before we actually get to Mike and one of the big questions as far as if this changes our disposition, not home or admission, but just the changes where the patient will be admitted to. Josh, the whole CEWA score, is this like an inpatient thing? Should we be using this in the ED? Do you have a piece of paper that like you'd sort of calculated out and that's how you decide what medications to give? Give us a overall thought on CEWA in the emergency department.
So CEWA is something I think that we're all familiar with, and it's always interesting when you look at the history of how we got here because it's often less glamorous than you imagine. But the CEWA score is developed in 1981. The CEWA-A, the A stands for alcohol, and it stands for the Clinical Institute Withdrawal Assessment. And then we probably are all now using the AR, which is the revised version of this, but it was developed on 38 patients that were being treated for alcohol withdrawal. So not a kind of study that you would expect to change all the practice for such a common condition. But what it really is good for is a couple of things. So this is really common, and it's helpful when we're dealing with something common to have a common language. And so CEWA gives us a common language to discuss this. So CEWA score of less than 8 means mild or no alcohol withdrawal present. Conversely, over 20 is severe, and in the middle is in the middle. It also gives us a protocol. We know from many different examples that protocols help with dealing for things and not letting the Swiss cheese effect, things fall through the cracks. And this is a condition that will persist for hours to days, alcohol withdrawal. And so it's going to be multiple nursing changes, but this protocolizes that the patients are going to be checked on. They're going to say what the CEWA score is, and that's going to, by most hospital protocols, trigger some dose of some sedating medication, usually a benzodiazepine. And that makes it very easy to treat this really common condition rather than having it be 10 different doctors and 10 different nurses, and they all have their own ways of treating it. Where there are some shortcomings of it is that, to Whitney's point, actually, there aren't very many hard objective signs in it. It's actually 10 items, and all of them are pretty much subjective. Tremor is one that you could say is maybe arguably objective, but so it's conceivable that patients could over exaggerate their withdrawal and be overtreated in seeking medications. Conversely, they could deny headache, they could deny nausea, and then their score would be lower than what is in reality. And so it's because it's so subjective, there is some risk of either undertreating or overtreating patients. And the other major downside is that it does require asking patients questions. There could be language barriers or issues if the patient is confused, which certainly can happen in this condition. So it's not perfect, but it's so much better than not doing anything, especially not anything that's standardized.
Gotcha. And we have not yet, but we will for folks to think, okay, so what do we do? How much do we give first, right? And I'm sure everyone has their own sort of way that they start treating patients with alcohol withdrawal. But before we get to there, Mike, I'm going to ask you this very simple question, and I'm going to give you a couple other rapid fire questions after this. So you have a patient that's in alcohol withdrawal, and I know you talked earlier about scarce resources. To me, it feels like you're not intubated, you're not going to the ICU. I mean, there's some caveats, of course, right? But tell me, where do you put patients that you're concerned, for example, with this specific situation, right? You're concerned about alcohol withdrawal.
Great questions, Mike. And the question here, does the presence of alcohol withdrawal alone mandate ICU admission? I think if we were just blanketly to say no. I think we've all had those patients that, as Whit said, are on the mild component of alcohol withdrawal that we've treated with oral medicines. They've started to have some improvement. And one of our facilities does have a unit dedicated to the care of these individuals. And so I don't think that everyone requires ICU admission. I think in this particular case, we've had a worsening of vital signs to a significant tachycardia, worsening tachypnea, hypertension, and then from a mental status standpoint, a decline in mental status, certainly in that DT realm. And in anticipation of the amount of therapy that he will need and the specifics regarding the frequency of airway monitoring with those medications, I think that it's a strong argument for this individual in this case to be admitted to the ICU, but I don't think all comers need or mandate ICU admission.
Yeah, and certainly when you look at not only what these vital signs are at this point, which is not great at 3:20 in the afternoon, but where they started from and how they've worsened. I mean, without a doubt, this guy's trajectory is to worsen and maybe even eventually have a seizure or to end up intubated. So, Mike, let me just take you out branch point all comers. If you have an alcohol withdrawal seizure and now you're mentating normally, but still have maybe some tremulousness and maybe even some mild tachypnea, right? Would that patient, would that specific patient, do you think mandate that they need to be admitted to the hospital, or could that patient be possibly managed at home? Again, one seizure, which we think is alcohol withdrawal related, but they're not currently seizing and they're meditating normally.
Great questions. I think probably more often than not, we would end up observing that patient for a little bit longer, likely an admission could be to just a floor or an IMC level of care. I suspect that there may be providers or folks that would look at that, observe them at an extended ED observation time, and continued improvement may discharge. But probably in my practice setting, we'd err more often on the side of admitting that person if they've actually seized in the ED.
Gotcha. I'm going to ask one other question. Heath had sort of mentioned some of the answers to this also before, but how are you differentiating an alcohol withdrawal seizure from DTs?
Well, I think overtly the seizure activity that we can diagnose from a DT standpoint, really the hallmark of DTs, which this patient is manifesting, is the change in mentation, and that can be subtle change in mentation to just overt encephalopathy, but it's that change in mental status for me that differentiates moving into DTs or a more severe spectrum of alcohol withdrawal.
And then the sort of funny question, the purple elephants thing, is that just like a cartoon, or is that actually something that you have seen frequently?
Not seen personally frequently, but I would
Okay.
absolutely say if they're saying that, then they're articulating some visual disturbance, which I think can be put on the encephalopathic or altered cognition spectrum.
Gotcha. Okay. So what happens next with this patient? The patient is given Ativan 2 milligrams IV. And again, we're going to talk about medicines in just a second here. He's placed on a cardiac monitor, pulse ox. He's now lethargic, difficult to arouse, and his heart rate's 151. And as folks know from the Bounceback series, all of this documentation is the actual documentation of the provider. Nothing's been changed for HIPAA reasons. Obviously, the patient's names and the physician names have been changed, but this is the actual documentation, just sort of copied and pasted from the chart. At this point, the patient is mumbling incoherently. So we saw the previous vital signs. This is at 3:20, right? And so now we're at 4:19, so an hour later. Orders for thiamine, folate, and 1 more milligram of Ativan, and the patient is now found to be seizing. So let's go to our next level here. And I think the answer to the first one, Mike, you've already given, so we don't really have to ask you about this again. Does this patient meet criteria for DTs? Clearly, the answer is yes. And we've also talked about some of those differences between those. So, Mike, give us just some brief thoughts on now. Clearly, the patient has DTs, and if we hadn't diagnosed that earlier, clearly we are doing that now, and the patient is seizing. Where do you start with things? And then, Whitney, I'm going to bring you in next to give some of your thoughts on that.
So in terms of treatment, Mike,
Yes.
for me, it's been in essence high dose benzos. We'll go aggressively along that line, and I believe that the literature does not demonstrate any superiority of one benzodiazepine over the other, whether it's lorazepam, midazolam, or diazepam. But more recently, something that we've done at our center is actually now include a phenobarbital protocol. And so we do have the option to choose that from phenobarb up front in terms of aggressively treating alcohol withdrawal, or we can stick with high dose benzodiazepine. So we can get into that more, but in essence, that's where either pathway for me at my institution with my resources will be going that route.
Well, Mike, let me just back up a tiny little bit. So the patient got Ativan 2 milligrams initially,
Mm-hmm.
and I'm not saying right or wrong, but what would you give as far as specific dose? Say, for example, that you're using lorazepam.
It's going to probably be, I think the 2 to 4 range is reasonable, but the way that this individual's looking, I'm definitely going to probably be on the 4. I'm going to be on the 4, if not be aggressive with repeated dosing. I'm just used to giving lorazepam. I think that certainly, once again, midazolam's fine, diazepam's fine, but I just have much more experience historically with lorazepam, so it's something that I'm going to use quite frequently and start off with at least 4 in this person.
Okay, so PIK, I'm not sure if that's actually your name, pick or not, but in the chat says hallucinations or hallucinogens equals pink elephants, major withdrawal, yes, not necessarily the same as DTs. Delirium equals waxing and waning, mental status. And he says alteration in DTs often has no correlation to reality, whereas hallucinosis might see a stethoscope and call it a snake. Heath, why don't we let you think about that one for just a second while we're asking Whitney what her thoughts are also on where she starts with medications once we have pretty clearly established that the patient is having DTs.
Yeah, I think my practice is pretty in line with Dr. Winters there. I trained at a place where I trained under a bunch of toxicologists. And so they are, one thing that I noticed that's different with this ED course is that we're incredibly aggressive very early on. And that requires one, aggressive with your dosing and aggressive with your reevaluations. And so I've trained with both phenobarb and lorazepam. And if it's lorazepam, it's pretty frequent as far as your repeat assessments with doubling the dose, and you go until they're out of it, until your vitals are normalized there. And then with phenobarbital, your reassessments, and Heath, you can probably spot check me on this and clean it up some, but the reassessments don't have to be as frequent. I think it's more of like every 15 minutes there. But it's the same thing where you're pretty aggressive early on. One of my attendings always said, if they're presenting to the emergency department with withdrawal symptoms, you're already behind.
So, Whitney, I'm sure your experience is exactly the same as mine. You blink and you look at the clock and an hour has gone by. And we have all these patients we're caring for at the same time. I would make a argument that exactly what you said is so important, that this is not the patient. I mean, this is probably your sickest patient in the ED. I mean, obviously, maybe not, but I mean, this is one person who has the potential. He actually is still alive, right? Has potential to get really bad. So having those frequent assessments is super important, even in a busy ED. Maybe just sort of force yourself to go back in there 2 or 3 or whatever number of times the next half hour. I don't think any of us really have that time for just, constant bedside attention unless you are working in a large shop that has multiple providers, right? But if you're in a single doc shop or, my shop where you have maybe 2 PAs or NPs and 2 or 3 physicians working at the same time, usually you're busting pretty quick and it's hard to get back in there. But I would just sort of force ourselves to get back in there and see this patient. So Heath, I'm going to have you just address that comment in the chat in just half a second, but let me bring your thoughts in as far as specifically your maybe benzo of choice or medication of choice, and when you start and get real aggressive with that patient.
Yeah, thanks, Mike. I think a lot of this may have changed back when we had a while ago, the shortage of benzodiazepines across the country. In my residency, we used diazepam. When I got to fellowship, we used a lot of lorazepam. So I usually tell people, what are you comfortable with, or what do you have stocked in your ER? I also think this is, if you don't have a pharmacist in your ED, this is where you need to call them, because you might be using some pretty big doses here. In my fellowship, it was tox seizures. You give toxic doses a lot of times of your antidotes, quote unquote. So I would use a dose of a benzodiazepine, and if it's not working, the next dose is doubled. But I really like phenobarb a lot, especially recently. We can talk more about the whys of that, and there's some more evidence, just because you're doing a little bit different mechanism here. You're upregulating GABA receptors and you're downregulating glutamate as well with phenobarb, and that's really nice. There's a recent paper that does show that maybe these patients, once you do phenobarb, they have to have a little bit higher level of care. But I like phenobarb. We used to give phenobarb to our alcoholics that were going back out on the street. So we'd infuse them with phenobarb and let them go, because we knew they were a really high risk, and the phenobarb would last a couple days, which kind of nice. And I'm surprised the tolerance that they often have here. So I like phenobarb a lot, but I would still start with benzodiazepine. And if I give 2 doses and I'm not getting anywhere, or I'm still getting breakthrough seizures, then I would go to phenobarb.
Okay, so let's just, for example, follow-up question. What is your initial starting dose of lorazepam, for example? 2 milligrams also, or do you start with 4?
I kind of look at the weight of this guy. I kind of like, 2 milligrams, 4 milligrams, and then, a lot of times, and this is another thing, is what's your nurse comfortable with? Because I've had nurses hand me, you give that, doc, I'm not giving that, because, and then of course that ties you up some more also. So, talk to your staff. What are you comfortable with? Let's start here. Let's reason and tell them why you're doing this. And again, this might be a great place, especially if you have a clinical pharmacist in your ED. This is really helpful.
Yeah, and having maybe a little huddle, right, with the nurse and the pharmacist saying, like, this is our plan and this is what we're going to do next. So, Sarah, thank you for your question. We're going to get to that in just half a second here. But first, Josh, and then Mike, I want to have your thoughts on this also. When should we consider intubation? Like Whitney said before, you don't want to get behind the 8 ball with things, right? And in the same way, this patient certainly seems, at least based on their vital signs, their mental status, that they're going downhill pretty quickly. Would you intubate this patient now, Josh, or would you try something else or see if our medications work first?
Admit I feel woefully inadequate because I'm answering before the intensivist. So if I wish you got in person, I could just say what he said. But no one said this point, but it is like the fundamental thing I remember from residency because it was hammered into me over and over is that the higher risk in these patients is under sedation, not over sedation. So if you sedate someone to the point that they're losing their airway reflexes, then you intubate them, but you don't stop the sedation because you're worried about the airway. You deal with the airway as it arises within the context of sedating them to the level of, we didn't talk about the RASS score either, but the Richmond Agitation and Sedation score is a common tool that's used. And just having the patient calm and kind of snoozing is the goal, but sometimes you overshoot that, and that's not a bad thing. That's actually probably protective. And so I would shoot for that RAS of 1. I like diazepam because the onset is faster a bit. And so you can kind of see if you're going to stand at the bedside, how quickly, the doses need to be escalated. But if you ended up that spot where the RAS trails into the -2 and beyond range, then your next move is to intubate them, and then sedating them becomes much easier, at least in terms of not worrying about the airway.
Awesome. So, Mike, before you answer, I just want to bring in Haley Pantel has a really cool thought is when this guy first came in, with the symptoms he had and our at least initial testing, chest x-ray, BNP, some of the tests we did for CHF came back not really making us more concerned about CHF. Could something like carbon monoxide, knowing that he lives in a garage, be consideration? So I love that thought that we're like thinking out of the box as far as some other things that could be going on as well. Also a thought from Sarah Perkes, if I'm saying your name right, or Perks probably. And Sarah is just wondering, well, PE, is that still a consideration? And I know there wasn't a pleuritic aspect that, physician documented that in the initial chart there, but, this guy, his legs hurt when he walks. Maybe he's been more sedentary. He obviously has some other cardiovascular problems or thromboembolic type of things that could be happening. So another good consideration. And maybe for another time, we could talk about risk benefit of sending this patient at this time out of the department to get a study for PE. I guess we could certainly start with the D-dimer, but I think these are both really, really nice thoughts because the fact that we initially didn't want to anchor on that heart failure diagnosis, even though it seemed like it when he walked in the door, that was probably what was going to be going on. But then with some things being equivalent, each different side, expanding our differential like that is a really awesome way to go. So Mike, I'm going to come back to you with the intubation, and I'm guessing you have something 100% different than Josh Russell to say?
No, I don't think so. I think Josh said it very well. I'm actually going to go to 5 really quick because Haley brings up something that's outstanding, as you indicated, Mike, in keeping our thought process broad. And with respect to refractory seizure activity, maybe we don't have labs up front, but we know that this is an individual with alcohol use disorder and they're not responding to benzos. Don't forget the bedside finger stick, and then also hyponatremia. So just things to think about in terms of continued seizure activity. With this individual, first off, I don't think everybody with alcohol-related seizures or withdrawal seizures needs intubation. I think in this particular case, we're likely headed towards that because we're already, as Whitney said, behind the proverbial 8 ball and getting his treatment. He's going to need probably escalating doses if he's not responding to benzodiazepines. His mental status is already suppressed. His oxygenation status was fair, but in the setting of seizures is likely to go lower or some aspiration event, and then the need to move on to potential other medications, whether that be phenobarb, whether that be propofol, or whether even dexmedetomidine. The likely trajectory for this individual is continued more medication, and I think it's always better when it's a little bit more controlled to secure the airway than crashing a little bit later and things are out of control and a little bit more hectic.
So, Mike, say for example, the patient is having, status epilepticus from their withdrawal, their, DTs, whatever the diagnosis, the specific name you want to put on it, and you do decide to intubate that patient. How is that going to be different than any other patient that you intubate as far as not knowing if this patient is still seizing? Would you use something like succinylcholine instead of rocuronium in this specific patient? Or would you try to get continuous EEG monitoring? How would you do this differently in this specific situation if he continued going downhill and if his seizures continued and were refractory to everything you're throwing at him?
Great question, Mike. I think that in terms of securing the airway, performing rapid sequence intubation, I would recommend continuing to use what you're most comfortable with. We are still going to use, for us, rocuronium, but that doesn't mean it's mandated, but we are still going to use the same RSI that we would normally do to safely control the airway. I'm more likely to be able to marshal EEG resources to determine if there's ongoing seizure activity. I know that that's a challenge for many in different settings, but securing the airway, doing what I'm comfortable with so I can secure the airway, and then working with colleagues to bring in those, whether it's a spot, whether it's limited montage, or whether it's, depending on the hour of the day, full EEG is what I will go towards.
So here's what we're going to do. It is 8:54. I'm going to reveal the outcome, and then I'm going to ask each of our panelists to give maybe a 45-second summary. In other words, I want you to give the thing that you want all of us to remember at the end of this hour here. So the patient was given 5 of Versed, started on a fosphenytoin drip, was intubated. The patient had a really horrible outcome and had an encephalopathy with permanent cognitive impairment, unfortunately. So what I'm going to do here is I'm going to, while we are giving our final thoughts, put up the CME QR code here. And why don't we go ahead and start with, let's see here. Why don't we start with Whitney Johnson? And we'll just sort of go back in the same order as we started initially. Whitney, what are maybe 30 or 45 seconds of final thoughts that you want folks to remember from this hour of their lives that they have given us today?
I think my thoughts would just be pointing back out to what Sarah and Haley brought up with these potentials for different diagnoses. So with symptoms being variable in every patient, right, we can't necessarily anchor onto one thing. We've got to keep our differential broad and remember that we work in parallel, not in series. And so at the same time that we would be working on stabilizing this patient, we should also be, you could fire off a VBG for carbon monoxide and get the airway under control. And ultimately he goes to CT before the admit. And so remembering that we're working in parallel would be important for alternative diagnoses.
Nice. Okay. Heath Jolliff, with your, and I'll pull this QR code back up in a second again here. Heath, with your both obviously emergency medicine experience, toxicology certification, what are some things, 30, 45 seconds, that you'd like folks to remember?
This is a complicated patient. Ask for help. early on. Talk to your intensivist, talk to your toxicologist, your pharmacy, because there's a lot of things this could possibly be. Talk to family, talk to the patient while he's still awake. Ask those questions. Have you been in withdrawal before? Have you ever had a seizure? Those type of things, because this isn't an easy case. And then reassess. And like you said earlier, Mike, this is a good one to have your team on board. Make sure your nurses are comfortable using these meds at maybe higher doses and using things that they might not be familiar with. And then I always dread, the next drug shortage, because maybe benzos and phenobarb will be on shortage next time, which I think phenobarb is actually on shortage right now. But just keep an open mind and continue to reassess and ask for help. And I put a
Folks want
link
to
to
take
a really nice paper there.
I was just going to point that out. Thank you for putting that in the chat. Okay, so Josh Russell, some final thoughts you'd like people to go away with?
I agree with everything that the other panelists said, and without adding to anything redundant, I just wanted to point out that there's some things just reading between the lines in the HPI that come across a bit judgmental, and I just be conscientious about how we're charting. There's more attention spent on the amount of alcohol he's drinking than characterizing his chest pain, for example. Mentioning the cocaine use, mentioning that he's African American. These things are not adding anything to communicating with providers or other clinicians, but they are giving a strong sense of how this doctor feels about this patient. And it's conveys a lot of frustration about this person's issues and how they're burdening them, rather than recognizing that actually in that moment he was suffering consequences of these issues with the alcohol withdrawal, which we learned can be a real devastating thing. And the second thing is that the earlier we can think about alcohol withdrawal, especially like when you've identified it in the HPI, the earlier we can start to treat it. And treating alcohol withdrawal with a benzo or presumed alcohol withdrawal is not only therapeutic and good to stay ahead of the 8 ball, but also it's diagnostic. So if his vital signs normalize quite a bit, we might be having a very different conversation, but you don't know that until you try a test dose of benzodiazepine. So as soon as you think about the CWA score and order that so you can delegate the nurses to continue it, but real quickly, if you see alcohol withdrawal or what you think was alcohol withdrawal, see how they respond, and that might change really a lot about how you think about diagnosis and disposition.
Awesome. And Mike, before you even give your final thoughts, I want to thank our folks who have given us an hour of your time, folks from as far away as Saudi Arabia, Nigeria, multiple countries around the world, and multiple states in the United States. So I'm going to put the QR code back up on here. And Mike, if you could bring it all together for us here, what would you like folks to take away from tonight?
15 seconds for time. Just beware that tachycardia, unexplained tachycardia. Please beware and be frightened of tachypnea, just that harbinger of potential critical illness. If you've made the diagnosis of alcohol withdrawal syndrome, be aggressive early to prevent this continued decompensation. You've got options from high-dose benzos to phenobarb, maybe even some dexmedetomidine in there.
Thank you all so much for giving your time to us this evening. I hope this has been worthy of it. And thank you all to the fantastic panelists, Whitney Johnson, Josh Russell, Mike Winters, Heath Jolliff. For folks who want to join us for Chapter 20, 35-year-old man with diabetes, history of IV drug use, and back pain, you can always register on the EM, like emergency medicine, Bouncebacks.com website, or you can scan this QR code to register for our Bouncebacks book club on Monday, March 4th, 8 p.m. to 9 p.m. Eastern Standard. Again, thank you all so much. All of these videos from all of the book clubs are posted on the website, as well as additional information from all of the cases. So thanks everyone so much again, and we'll look forward to seeing you all next month.
Mike.
Thanks, Mike.
Thank you guys.
Yes.
Great job. Pleasure to work with you all this evening.
Yeah, and when I say that, I mean it's really from the bottom of my heart that you guys have taken an hour away from your families and for the time to do this. But these are tough cases, and we have some things that we've been doing it for a long time and they seem easy, and then other ones even that you have been doing it for a while and it seems more difficult. So thank you all again. I'll sign us off and talk to you all soon. Thanks again.
Great
Have a
night.
good night.